To speak about combination strategy, I should have entitled my presentation also Combination Strategy, the Past and the Future, because I think we are now on the threshold of change in the concept of combined treatment for target therapies. So first of all, there is a strong rationale of target therapy combination in the literature. I just picked up some reference with first experimental data that evidence an additive or synergistic effect on tumor cells as well as on peritumoral endothelial cells. And we know that on a general point of view in oncology, combination treatment was and still is, with different drugs, a way to improve the treatment efficacy. We know that currently approved treatment in metastatic renal cell cancer are not curative, and we all know that patients eventually develop progressive disease due to acquired resistance mechanism. So combination of active treatments represent still in metastatic renal cell cancer a way to maximize treatment effect. Just to remind you the number of agents that right now are available. And of course, the first thing we had in mind when we tried to maximize the treatment efficacy was to use these available agents and combine them to reinforce the pathway inhibition. So you know there is two where we distinguish two different types of blockade or inhibition and with the combination of treatments. The total VEGF pathway inhibition, or some of us call that the vertical blockade, or what we can call the dual pathway inhibition, or some other call that horizontal blockade. And this combination will block the VEGF pathway together, for example, with the mTOR pathway inhibition. And this could be maybe more easy to answer on that very useful cartoon. I thank every time Brian Rini and Mike Atkins who published this cartoon that is very useful to explain the mechanism of action. So here you have what we call the vertical blockade and the VEGF pathway complete blockade with Bevacizumab, who of course blocked the VEGF itself, and the TKIs who are inhibitors and blocks the functioning of the receptors to the VEGF. And on the other hand, you have the PI3 kinase mTOR pathway, and of course it's very interesting to combine the mTOR inhibitors together with the VEGF pathway inhibitors. So a number of investigators attempt different combinations throughout phase 1 trials, and have rather rapidly we had the feeling that Bevacizumab together with VEGF receptor or TKIs was a complicated thing to conduct. And indeed, we had the observation that this combination could induce potential severe vascular effect like microangiopathy, thrombopenia. mTOR and VEGF TKIs, we know that this combination gives enhanced toxicities, and we know that this type of combination is only feasible at reduced dose. And finally, the combination that looked the most easily feasible was the combination between mTOR inhibitors and Bevacizumab, since both everolimus and temsirolimus together with Bevacizumab looks feasible at full dose. And this explains that according to the conclusion of this combination phase 1 trial and having had potential gain in efficacy, several phase 3 trials were launched with this type of combination. We have at least 3 phase 3 trials, Bev together with everolimus compared to Bev and interferon in first line, or Bevacizumab and temsirolimus versus the same control group. And we also have a second line phase 3 trial with the combination of everolimus with Bev compared to everolimus by itself. And we know that some of the results are coming soon, and I think it's interesting to have these results. Anyway, in the meantime, phase 2 trial will perform always with the same combination, Bevacizumab and mTOR inhibitors. And there are 2 main phase 2 that were conducted. The first was the association of Bevacizumab together with everolimus, and in two groups, it was a non-randomized phase 2 trial, but two groups of patients who were naive from treatment and pre-treated patients, and the median progression-free survival obtained throughout this combination was more than 9 months in naive patients and a little bit more than 7 months in pre-treated patients. And the second trial was the TROVA trial that was exploring the combination of temsirolimus together with bevacizumab, and there were two control arms with sunitinib and bev plus interferon. And this was a randomized phase 2, and the combination arm, which the experimental arm, gave again a median PFS of 8.2 months. Sorry. So I think that the conclusion of this phase 2 trial are that no major additive effects or synergistic effects can be expected from this sort of combination. We know that we have, on the other hand, an enhanced toxicity, and I think, unfortunately, we are not expecting a dramatic positive result from the phase 3 trial in terms of efficacy. So if there are any role left for the combination of available agents, I think one situation that could be interesting, but it's difficult to investigate, could be salvage treatment by addition of bevacizumab to overcome resistance to TKI, because we know that during TKI treatment we have an important augmentation of the VEGF level. So probably this could be still a way to use this kind of combination. And we have some case reports that could be of interest. The first one was done by with the combination or the addition of bevacizumab to sunitinib, and the last one with the addition of bevacizumab on everolimus. And there is right now online a very interesting and complete review on the combination of target therapy that can give you an idea of what is or could be interesting in terms of strategy. So now what about the new agents? We know that we have new anti-angiogenic TKIs, more potent, more selective, and probably less toxic. We have also new immunotherapy agent that looks very interesting, and we now have a new generation of TKI, target TKIs, usually called double target TKIs, that represent a way to combine different mechanisms of action. So the new VEGF targeting TKIs that looks very interesting, you already heard of them, are mainly axitinib and tivozanib. They are very selective to VEGF receptors, and they look very potent. And obviously axitinib brings some advantage in terms of what we call off-target effects, since, for example, a number of toxic effects observed under sorafenib were not so important and so frequent when we use axitinib. And tivozanib, you can have some data on the publication, online publication of the phase 2 trial that obviously confirms the interest in terms of activity, and again, there is a limited off-target toxicity with this product. So axitinib and tivozanib with this specific toxicity profile will probably be easier to combine with other drugs. So now to the new immunotherapy agent, there are mainly two interesting candidates. I would say the first one, you probably know it because it's right now available for metastatic melanoma treatment, but interestingly, Jimian already published some data with ipilimumab in metastatic renal cell carcinoma already in 2007, and there was some activity when this drug was used alone. And the most recent, probably the most recent agent, immunotherapy agent, is the anti-PD-1. And we also have some promising preliminary data from phase 1 trials. So I think right now, both drugs are being developed in metastatic renal cell cancer, together with TKIs, trying to maximize the treatment efficacy. So the last strategy is represented by what we call double class target agent. There is a number of them, and Mike Atkins already talked about some of these agents. Of course, they target different targets that we usually have in hand, because they target the angiopoietin, the FGF receptor, or the the PI3 kinase pathway together with two mTOR situation, mTOR-C1 and mTOR-C2. So it's really some kind of revolution in terms of development. I just picked some dual target inhibitors because there are dozens out there, and I'm not sure it's interesting to have all the catalog. Dovatinib is probably one where the development is rather rapid, is now in phase 3. And there is VEGF receptor inhibition together with VEGF, regorafenib, combined Tie2 and VEGF, ferretinib, and cabozanib are interesting because they block c-MET, and last the p-TRK kinase and mTOR-C1 and C2 inhibitors. So some agents appear rather toxic, but some others look very promising. And I'm sure that a number of them really bring potential breakthrough for the next generation treatment. So in conclusion, I think that combination of available agents for MRCC treatment have not yet found their role yet, but I think we will be very surprised in the future, and hopefully new compounds will offer a number of different perspectives to our patients, and I think that combination treatment remains an important strategy for the future. Thank you.